All right, hi everyone. Thank you for joining us today for Grand Round. It is my absolute privilege to introduce our visiting professor. Dr. Evan Kalen Haidu earned his medical degree and his residency at University of Montreal in ophthalmology, and then went on to do an ASOPLS fellowship at UCSF under Thyroid. Since 2017, he's been in practice and has provided exceptional care and was made much innovation in teaching and research. He practices the full spectrum of oculoplastics, including orbit, lacrimal, and eyelid disorders. He's had over 42 peer-reviewed publications, 29 conference podium presentations, and 19 guest lectureships. He's had multiple awards, including Best Teacher at both UofT and UCSF, Best Research Supervisor at UofT, and Best Young Member presentation at all ASOP. On a more personal note, I do recount when I was a resident doing an elective back in about 2018. And Evan always had a way of teaching in a way that kind of made you expand beyond your understanding of something. And we were doing reconstructions at the time, post-Mohs, and we're talking about eyelid reconstruction. And it sounds relatively simple, but he just told me very plainly, you can put a flap on a flap, a graft on a flap, but not a graft on a graft. And that basically allowed me to expand my understanding of how you reconstruct eyelids and all the ways to do it. And that's exactly what I needed to hear at that time. So Evan has a way of teaching that is really exceptional, and it is my honor to introduce him. Sure is.
The audio is in the room.
Yes.
Virtually will be able to hear me. It's a deal. So the title of my talk, thanks again, George, for the introduction. No pressure on me. So the title of my talk is Tocilizumab for Thyroid Associated Orbitopathy, Canadian Perspective. I have no conflicts for any medications or products that are discussed in this talk. So I'm going to just start by just setting the stage, and that's to say that thyroid-associated orbitopathy, or TAO, is a relatively common and at times highly morbid disease. Tocilizumab, or TCZ, for the rest of this talk, is an immunomodulator that can be employed against TAO. Certain oculofacial plastic surgeons at the University of Montreal, including myself, have a unique experience with the medication. And the goal really of this talk is going to be to explain how, especially in the Canadian context, tocilizumab can be a valuable tool in the armamentarium against TAO. But we have to remember that TAO really is a nuanced disease and can be quite complex to manage. There really is a sea of many, many different immunomodulators, and it's very easy to get confused, especially if you're inexperienced or you're discussing difficult cases. So I'm going to give a fair amount of time to just laying the groundwork so that we can dive into the details of tocilizumab and everybody understands and everything's clear. So we'll lay the groundwork, talk about terminology and the general management of TAO, current immunomodulatory therapies, review the highest quality literature on tocilizumab, discuss when and how we employ it, and we'll do a deep dive into our results at the University of Montreal so far. So what is TAO? It's an immune-mediated inflammatory disorder of the orbit. It's strongly associated with autoimmune thyroid dysfunction. We know that the vast majority of patients have Graves' hyperthyroidism, but about 5 to 10% of patients are either hypothyroid or euthyroid. We know that there's a general association between the thyroid-stimulating immunoglobulin, which is a type of thyroid-stimulating hormone receptor antibody, and both the presence and severity of the disease. But there's a whole swath of other antibodies and proteins like anti-TPO or microsomal antibody, thyroglobulin, thyroid binding inhibitory immunoglobulin, the list goes on. And all of these proteins are either poorly correlated with TAO or are not very reliably measurable to date. What are the risk factors? These are important. We're going to get back to these later on in the talk. So there's definite risk factors that aren't debatable based on high quality studies. The first is age. We know that that makes the disease more prevalent. It's very rare to see it in very, very young patients, not impossible, but rare. The older you are, the higher the prevalence and the more severe the disease. Females have a higher prevalence of disease, but tend to have a less severe presentation. If you smoke, it's bad across the board. Thyroid dysfunction increases both prevalence and the severity of the disease. Radioactive iodine, radioactive iodine typically in these patients given in the context of poorly controlled Graves' hyperthyroidism, that is definitely something that can both trigger and increase the severity of the disease, but it's largely eliminated with prophylactic steroids in a select group of patients. There's other risk factors that are often published that are, I would say, more debatable, and they include hypercholesterolemia or the absence of statins. We're not sure which one it is. Diabetes, low socioeconomic status, low vitamin D levels, and oxidative stress. The ones that are in red are all those that are modifiable, and like I said, that's important for later on in the talk. So the mechanism of the disease is really not very well understood. We know that the thyroid stimulating hormone receptor and the insulin-like growth factor 1 receptor mediates the abnormal behavior. And it's sort of this downward cascade of events because of these receptors that include fibroblast proliferation, the synthesis of a whole bunch of abnormal products within the orbit, and cytokine release. Due to this abnormal adipocyte and fibroblast behavior, there's inflammation and expansion of the fat and orbital muscles. And also due to this expansion of volume within the orbit, patients typically have a stereotypical set of radiological and clinical findings, and we'll quickly go over them. So again, this is all setting the stage so that when I show you guys images of patients and explain how certain patients were managed with tocilizumab, that you're not completely lost. So here's a normal orbit as a point of reference. What you can see on the coronal cut is I'm pointing to the medial rectus. That medial rectus looks completely normal in terms of its volume. Here's the horizontal cut, and you can see on that axial cut that if you draw a line between the anterior lacrimal crest, and the lateral orbital rim, the eye is basically bifurcated by that line. Here's a patient with thyroid associated orbitopathy. You can see that the medial rectus muscle is much larger than the control. And you can see if you were to draw that line, the eyeball is basically entirely anterior to that line that was drawn. So obvious proptosis. Here's a patient that has prominent fat expansion. And you see that, again, this patient is very proptotic and the globe's entirely anterior to the line, but the muscle actually looks stretched and thin. And that's because fat has increased in this patient's orbit as opposed to the muscle volume itself. And these are kind of the patients that we all dread the most. And those are patients that have very little proptosis because their eyelids or septum are very thick. The eyeball can't anteriorize on itself and decompress the orbit naturally, but they have very large muscles. And for that reason, you have an increased volume in a hermetically sealed space that can't decompress itself, and you get crowding at the apex, and those are the types of patients that get this thyroid optic neuropathy. Clinical findings, we'll quickly go through these. So these clinical findings, just have to remember, can occur in any combination without a fixed order. And they include lid retraction, von Graefe sign. Von Graefe sign is an active sign. You can't really take a photo of it. It just means that upper eyelid retraction gets worse as the patient is depressing their globe. Lagophthalmos, proptosis caused by fat and muscle expansion, restrictive strabismus, corneal exposure, which is secondary to proptosis and or lid retraction. And then, of course, the dreaded dysthyroid optic neuropathy, which is compression of the optic nerve by enlarged extraocular muscles. So here's a patient with unilateral lid retraction who doesn't have proptosis, bilateral retraction without proptosis, bilateral retraction and proptosis. Again, severe proptosis with bilateral retraction, and this is isolated restrictive strabismus. So it's not a sequential series of events, it's kind of a grab bag of you name it. An important concept that's going to be really central to the rest of this talk is activity. So remember that patients can insidiously or rapidly develop any of the 7 signs that I explained to you guys without obvious inflammation. You can also develop any of the 7 signs in the context of inflammation. And inflammation means pain, tissue, edema and hyperemia, and worsening of strabismus, visual acuity, and proptosis. So something actively is going on here. The clinical activity score, or the CAS, is just a method of rendering objective inflammation in TAO. It's kind of like how if you're following a patient with anterior uveitis, you don't say they have, so-so uveitis or bad uveitis. You have grading criteria of 1 to 4 plus cells. It's a way of objectifying these patients, and it's a way of studying them. And the CAS is a binary scale with 7 possible points for active inflammation at the initial visit and 10 points at follow-up. I'm going to show it to you. If your CAS is 3 or more on 7 for the first visit, or 4 or more on 10 for follow-up visits, this implies quote unquote active disease, okay? And we know that active disease yields an 80% positive predictive value and 64% negative predictive value for clinical improvement with prednisone and steroids. So it has a use because studies have shown that once you're above these numbers, there are good odds that you'll respond to steroids. And if you're below those numbers, there are poorer odds that you'll respond to steroids. It doesn't mean you only give steroids in these patients, but it means that we know statistically there is a relevance to being quote unquote clinically active. Here's the actual score. You don't have to know it off by heart right now, but the point is that the first 7 units are all objective findings that can be on initial or a follow-up exam. So tissue hyperemia and edema, for pain. But these last 3 points are only things that can obviously be on follow-ups, right? Because it's worsening of proptosis, worsening of eye movements, decrease in vision. So that's only on follow-up visits. Now, it is an imperfect system, right? It's binary, so it's a yes or no. Each feature is weighted equally, and not each feature is equally important. There's no category for dawn or a category for the cornea, but it is the most utilized system in research, and it is also the system that I use and most of us use at University of Montreal and for this talk. So when I say somebody is active, you now understand what I mean for the rest of the talk. Is this clear so far? Yeah. Okay. So here's a patient who's clinically active. She does have retraction and some proptosis, but if you were to jot all of her points together when asking her all the clinical activity score questions, she's a 6 on 10. So she's clinically active. This patient is clinically active. He's a 4 on 10. And this patient who doesn't look that inflamed is also technically clinically active. She's a 5 on 10. If you add up pain with extraocular movement, spontaneous pain, worsening strabismus, worsening vision, she's a 5 on 10. So she's active. So how do you manage these patients? This is kind of a central slide that will be clear, that will become also clearer as the talk goes on. The first point is really for every single patient, maybe the most important thing that you can do is manage modifiable risk factors. So that means, to be specific, that you have to tell every patient that if you're a smoker, you cannot smoke, either be exposed to primary smoke or secondary smoke. You have to ensure that the patient is euthyroid. I mean, it is surprising the number of times I'll get consultations where the patient's seen like a comprehensive ophthalmologist a year earlier, was sent to me for thyroid associated orbitopathy. Nobody ever asked, do you have a GP? Are you known for thyroid hormone imbalance, or do you smoke? They come and see me a year later and they've lost like 50 pounds. They're tachycardic, they're sick, they have a goiter, they're a pack-a-day smoker, and no one has told them anything. Okay, so these are important things that are really easy. Like I said, it's low-hanging fruit for every single patient. Next is prednisone coverage. Usually what I do is if a patient comes in, they almost always know that their endocrinologist is aiming toward radioactive iodine. And I always say, who's your endocrinologist? I'm going to send them a message. It's important that in your case, it's more detailed. We can talk about it later if you're interested, that you need prednisone coverage and prophylaxis after radioactive iodine is given. The other easy ones are, again, family doctor, cholesterol has to be managed, diabetes, vitamin D. I usually order actually a cholesterol, diabetes, and vitamin D panel also on my patients when I first see them. So step 1 is the patient walks in and you do the easy thing, which is you think about the modifiable risk factors and you ask it on every single patient. Step 2 is a little bit more nuanced, which is that I'm always asking myself 2 concomitant questions. The first question is, how severe is the disease? And I'll explain what that means. And the second is, are they acute? Severity has like technically a very specific definition per the UGOGO guidelines, which is like our main thyroid group. But what you really have to know is that mild disease means the patient has TAO, but they're not that bothered, okay? They don't have very significant retractions, strabismus, proptosis that's affecting their daily life. Moderate to severe means there is a significant impairment in their quality of life because of these findings. And sight-threatening obviously means that they have either dysthyroid optic or corneal. So here's the general approach. Let's say somebody is inactive, so they're clinically inactive for the clinical activity score, and they have mild disease, so they're not that bothered by their illness. That usually just means you're holding their hand. It's like surface lubrication, supportive measures like sleeping with your head elevated at night, reducing your salt intake. There isn't like very much that you do with these patients. What if they're active? So their clinical activity score says that they're active and they have mild disease. It's the exact same thing as the previous category, but based on a large New England randomized controlled trial, I usually add selenium. It's a little bit nuanced also, but I usually add selenium in these patients, 100 micrograms twice a day for 6 months. Now, what if the patient is inactive? So they are inactive for the clinical activity score, and they are having moderate to severe disease. Well, these patients aren't actively inflamed. They usually don't need immune suppression, but because they have significant proptosis or retraction or strabismus, usually aiming towards surgery in these patients. But if they are inactive and have sight-threatening disease, almost always these types of patients end up with urgent decompression because there isn't much, in most cases, again, it's nuanced, but in most cases, you're not going to immune suppress them, or if you do, it usually doesn't work, and they usually need decompression. But now, kind of the most important category for the rest of this talk, which is what if they are active for the clinical activity score, and they have moderate to severe disease, or they have sight-threatening disease. These are patients that we're going to start with immune suppression, and who we're going to talk about for the rest of this discussion. So patients with who need immune suppression in the context of active, moderate to severe TAO. There really are a multitude of immunomodulatory agents for TAO and these patients specifically. And here's a big list of them. There's steroids, there's non-biologics and radiation, and there's biologics like rituximab, teprotumumab, and tocilizumab. We'll start with steroids, and then we'll see I'll go much quicker through the rest of them until we get to tocilizumab. So steroids are important because we still use them a lot in pretty much most of the world outside of the US. And it's a broad and potent anti-inflammatory and immunosuppressant. We know that the oral and IV routes are both acceptable, but the IV route is more effective and likely better tolerated. There have been multiple randomized controlled trials on steroids for treatment-naive, active, moderate to severe TAO. Treatment-naive just means that they haven't had previous therapies before steroids. So the first thing they're given is steroids. The most popular regimen is the UGOGO regimen for these patients. So it's solumedrol or methylprednisone, 500 milligrams once a week for 6 weeks, then 250 once a week for 6 weeks, and that costs $500 Canadian. The response is not always easy to tell you because a lot of the studies that look at steroids are over the past 30 or 40 years, and the outcome measures have been sometimes a little bit wishy-washy. Sometimes it's like any improvement in the CAS, or a 2-point improvement in the CAS, or soft tissue features, so it's a little bit subjective. But you can say overall that up to about 80% of patients, if you give them steroids because they have active, moderate to severe TAO, will get much better and not need a further intervention, okay? But when dysthyroid optic neuropathy is present, steroids can still be used. However, they're only in the best study effective in quelling dysthyroid optic neuropathy in about 40% of patients at 6 months follow-up. So what that means is that anywhere from 20% to 60% of patients who you'll be giving steroids to are either immediately resistant, so they don't improve on them, or they will relapse once the steroids have stopped. If we look at the categories that I highlighted in blue, we'll quickly go over them. The non-biologic immunomodulators like CellCept, cyclosporin, azathioprine, methotrexate. I'll just summarize it by saying that the most convincing positive results belong to CellCept. And we know that a large trial showed that CellCept plus IV steroids did better than IV steroids alone at 24 weeks after the end of treatment. But both groups were actually pretty similar in terms of recurrence of activity over time. So not exactly a slam dunk. CellCept isn't sort of like a magic pill in these patients as a general rule. Radiation is an important one. Radiation is not only something that was largely pioneered by Peter Dolman at UBC, but is something that I think is a little bit underappreciated, especially in the US, less so in Canada and in Europe. But when compared to steroids alone, we know that radiation plus glucocorticoids significantly decreases the odds of developing dysthyroid optic neuropathy. So you look at the cohort of patients that got steroids plus radiation versus steroids alone, and you follow these patients for like 3-4 years after their treatment. This was a large publication in AJO. The group that got steroids plus radiation, not a single patient developed dysthyroid optic neuropathy, and there was hundreds of patients in this study compared to the group that got steroids alone, and it was like a 14% odds of developing DON over follow-up. Radiation is most likely beneficial in cases of worsening strabismus. And radiation, importantly, is likely of little use in patients who do not respond to steroids. So usually if you give them steroids and they don't get better, often they will not get better on radiation either. So when a patient is active and has moderate to severe disease, typically in my practice, not always, but typically I'll give a dose of solumedrol IV. And if they very quickly respond and get better on Solu-Medrol, often that means that I'm going to also send them for radiation. So they're going to get both. Not every patient, but a big chunk of them. Rituximab. Rituximab was kind of a hot topic a few years ago. And what I'll just tell you is that it has conflicting results, okay? There was one randomized controlled trial that showed rituximab monotherapy that was superior to steroids at 24 weeks, but there was another trial that showed that it did absolutely nothing. So it's debatable. It doesn't mean that I don't use it in select cases, but it's not across the board successful. So we talked about steroids and everything that I highlighted in blue. Then there's, of course, teprotumumab, which requires a minute or so of discussion because everybody talks about teprotumumab now. It's a very, very big drug. It's used by a lot of our colleagues in the US. Teprotumumab is an IGF-1 blocking antibody, so it blocks the IGF-1 receptor. And it has been studied very, very extensively in large New England Journal randomized controlled trials that look at patients who are treatment naive, okay, with moderate to severe active TAO. And what I can tell you is that without a doubt, 3 weeks after the last dose of teprotumumab is unquestionably superior to placebo across the board. So it does a much better job at reducing clinical activity, much better job at reducing proptosis, quality of life improvement, and diplopia. So if you look 3 weeks after the last dose, it is clearly a fantastic medication. It was approved for that reason in the US by the FDA for any patient for any reason who comes in with thyroid associated orbitopathy, but it costs between $300,000 and $500,000 US. There's a big push for that medication. There's a lot of colleagues who give a lot of patients teprotumumab, even for mild reasons. However, you have to remember that the best non-pharma sponsored studies on teprotumumab with much longer follow-up have shown different results. So longer term studies that look at patients anywhere from 9 to 20 months after treatment show that only about 30% of patients have a durable clinical activity response. So their CAS in only about 30% of patients stays inactive at about 9 to 20 months follow-up, depending on the study. We also know that 60% of patients have their proptosis regress either back to baseline or worse than they were at baseline in these studies. And that long-term, the longest term studies we have, the longest was at a Cleveland clinic at 20 months follow-up. It had zero effect on diplopia and almost no effect on proptosis either compared to baseline. So if you also look at teprotumumab, another issue is that there's mild to severe and sometimes potentially permanent hearing loss. And it really is very wide. Some studies have as low as 5%, some studies as high as 40%. So that's an important side effect. And it doesn't mean that teprotumumab is bad. It can be used in patients, definitely, especially in select cases. But there are some realistic side effects or realities of the medication that people have to understand. And most importantly, in Canada, although it's technically approved by Health Canada, it doesn't have reimbursement status. So if you have a patient and you want to give it to them, there's no way they can actually get the medication unless they pay out of pocket. And even then, that's complicated because of recent political issues with the US, where because of drug pricing, long story short is you basically can't get it in Canada right now, no matter how hard you try, even if you talk with Amgen. So if we look at these immune suppressants, if we look at these immune suppressants, the question is like, okay, I gave you guys this whole quick survey of like what the medications do, what their indications are. What do you do here in Toronto? What do I do in Montreal? What do we do in Canada? Well, if a patient comes in with active, moderate to severe TAO, I think a very reasonable approach that pretty much everybody takes here is steroids, plus or minus radiation, depending on your practice, especially if the patient responds to steroids. That really is a first-line justifiable treatment in Canada. Okay? That's what most of us will do now, and in Europe. So steroids plus radiation is first-line treatment, especially in my practice. But what happens when you're outside of the US, because everybody gets Tepro in the US pretty much, when a patient fails steroid therapy? And failure means that their symptoms and their CAS fail to improve on steroids, or they develop thyroid optic neuropathy on steroids, or they relapse after steroids, or they have unacceptable adverse events or contraindications to steroids themselves. So what do you do in these patients? One thing you can try is giving them steroids again. That's actually never been studied in any type of trial whatsoever, but it's something that some people do. You can look at radiation, but remember I told you that if you just gave them steroids and they failed steroids, they're very unlikely to improve on radiation. So it's often kind of not really an option. There's all the medications here that I have an arrow with, and they have really far from overwhelming results, and not a single one of them has been studied in a large series or a prospective fashion or in a randomized trial in steroid-resistant patients. So we have no idea. We don't know what happens with these medications for patients that have failed steroids. Thyroid, I told you that there's big problems with access in Canada. There are side effects, and there are more questionable long-term results in a significant chunk of patients. So this is why we have to talk about Tocilizumab. So it's kind of like the last soldier in the army in these types of patients. So what is Tocilizumab? It's also known as Actemra. And I'm going to just take a sip of water. Is this clear so far? Not too quick? Okay. So Tocilizumab or Actemra, it's a monoclonal antibody targeting IL-6. IL-6 is important. It's a pro-inflammatory cytokine that's excessively secreted by fibroblasts and TAO. It's extensively studied in rheumatoid arthritis. We have to remember that, like, yes, for us, TAO is very common, but for the world, it is not. Rheumatoid arthritis is very, very common for the world. So we're talking about trials that have thousands of patients that are randomized. And if you look at rheumatoid arthritis patients, we know that Tocilizumab intravenously plus a disease-modifying agent like Plaquenil or azathioprine that are given for rheumatoid arthritis, those patients are superior to individuals who get the disease-modifying drugs alone. That's what's been clearly shown in rheumatoid arthritis. And we also know that subcutaneous Tocilizumab, which is a unidose, there's no modification of the dose of subcutaneous Tocilizumab, is non-inferior and equally safe to IV Tocilizumab. It is approved by Health Canada. There's the picture, by the way, of the unidose injector for Tocilizumab. It's approved by Health Canada for rheumatoid arthritis, GCA, juvenile arthritis, cytokine release syndrome, and of course, COVID-19. It made a lot of news for COVID-19. It has absolute contraindications, which are a known allergy to the medication or any active infection other than COVID-19. There are risks. So if you sort of collate all of these very large trials on rheumatoid arthritis and other illnesses, and you look at the risks of the medication, very quickly, neutropenia, elevated liver enzymes, elevated cholesterol, triglycerides, GI pain, diverticulitis, infections in up to 10%, death in less than 1%, which was similar to placebo. And overall, if you look at these thousands of patients, about 5% discontinue their treatment due to these adverse reactions versus 3% of controls. So when somebody needs Tocilizumab, they also need a workup prior to the initiation. And I'll talk about how that works in my hospitals. So they get a liver panel, they get basic CBC electrolytes, and creatinine, cholesterol panel, and obviously a basic infectious workup, okay? And patients need these bloods repeated every 3 months while on the medication initially, but then the internists tend to spread it out much more over time. What are publications on Tocilizumab in thyroid associated orbitopathy? And there's two important ones. So the first one is a study that came out of Spain. It's a well-known group. It's a single center case series that spanned 9 years. They only included patients with active, moderate to severe TAO that quote unquote not responded to IV steroids. I don't really know what that means, but they just took patients that they felt didn't do well on steroids. There wasn't like a clear inclusion criteria other than just not doing well on steroids. All patients had a required duration of greater than 3 months without therapy prior to Tocilizumab. So presumably there's no patients with this thyroid optic neuropathy. If they have DON, usually they're doing something for them over the past 3 months. They gave 8 milligrams per kilogram IV once a month. There were 54 patients, and the median number of infusions was about 4. So usually 1 infusion once a month for 4 months on average. And they actually had a very, very impressive follow-up of 2 years subsequent to the last dose. You have to remember, for a lot of these other studies, like for teprotumumab, it's like usually 3 weeks after the last dose. This is 2 years. They had really dramatic results for clinical activity score that actually did better than if you compare it to teprotumumab in patients that had not received steroids. And if you look at the decline of CAS greater than or equal to 2 points, 91% of patients after the first dose. The rate of inactivation was 16% after the first dose and 89% by the last dose. And what's also very impressive is that only 7% recurred during that 2-year follow-up. So that means that 93% of patients had 0 recurrence, which means their clinical activity score did not get worse by at least 2 points. And they did not require any further treatment over their follow-up at 2 years follow-up, okay? So that's in a relatively large cohort for a disease that's relatively rare, like thyroid associated orbitopathy. Based on this study, they went ahead and did a randomized controlled trial. This was an AJO. And that same group did their randomized controlled trial. It's all from Spain. They only included patients with active, moderate to severe steroid resistant disease. They define steroid resistant in a much more objective way here. And they excluded, though, there was a little bit of cherry picking, although these were patients that failed steroids, so they're already tough, refractory, intense patients. They excluded people who smoke and who had thyroid optic neuropathy. They gave tocilizumab once a month for 4 infusions, and they compared it to a placebo. They had 40 weeks follow-up in total after the first dose, so that means 28 weeks follow-up after the last dose of tocilizumab. I'm not going to go through this whole slide, it's too busy, but the point is that the groups were the same in terms of age, percentage of female, their clinical activity score was the same at baseline. The TSI antibody, remember I told you that that's usually a corollary for how severe the disease is, not always, but usually. It was actually worse in the tocilizumab group. And the point is that, again, they had really promising results with regards to CAS. CAS improved by at least 2 points in 93% in the treatment arm at week 16, which was better than placebo. Disease inactivation, much better in the treatment arm than placebo at week 40. And reactivation was defined as any need for any new immune suppression or any other therapy after treatment, was 0% in the tocilizumab group, 21% in the placebo group. And little to no improvement in subjective diplopia in either group. And by week 40, there was a mild improvement in proptosis in the tocilizumab group, but it was 1.5 millimeters. It's not extremely dramatic, but it was better than the placebo. So how do you conceptualize everything that I've sort of told you so far with regards to tocilizumab? I would say that the best way to summarize it is that the highest quality publications to date involve steroid-resistant patients, which is unlike other medications in TAO, and patients that almost always don't have none. Despite no large randomized controlled trials, it appears to be effective at reducing disease activity for at least 2 years after the end of treatment. I say no large randomized controlled trials because the randomized controlled trial I just showed you had something like 15 to 20 patients in each arm, so it's not gigantic as a trial. It also has a likely minimal effect on diplopia and a mild effect on proptosis long-term. And it's worth noting that in Canada, this is at least in Quebec. I know how much it costs in Quebec. I don't know in Ontario, but it's just over $1,000 Canadian for 1 IV infusion for a 70 kilogram patient, and it's $300 for 1 subcutaneous injection. So we're talking about like a fraction of a fraction of a fraction of a fraction of the price of most other medications. So why were we so interested in this at the University of Montreal? Why was I so interested in it? Well, for many reasons, it's ideal for our practice in Canada and in Montreal. Well, it has long-term data that's pretty good with regards to CAS. The second reason is that it's available and it's inexpensive. And the third is that it's actually pretty easy for our workflow. I don't know how it works everywhere, but I can tell you that where I work in my hospitals, I have a good relationship with the internists. It helps to have some that were in my medical school year. And when we knew we wanted to start giving tocilizumab, it required calling these people up, having a meeting, saying, we want to give this medication, but I'm not an internist. I don't know what to do if somebody develops hepatitis or neutropenia on this medication. I'll be the head of the orchestra and coordinate, but I need you guys to prescribe the medication, to do the bloods, and to help me from the non-ophthalmic standpoint, okay? And we have more than one internist who's willing to play ball with us, who I can easily call on the phone. So we have internists that are keen and that work hard and that work hand in hand with us. So they prescribe the medication, they do the labs, and they take care of all the systemic aspects. When given subcutaneously, it can be self-administered at home. This is a huge one, okay? There's not a lot of people who do complex orbit in Canada, and we get a lot of patients. I get a lot of patients that come in from like 10 hours away, 11 hours away. So it's not easy to see these people, and adherence to follow-up is a big problem. So the way it works is that private insurance companies, if the patient has private insurance or the RAMQ, which is our version of OHIP, they get contacted with justification for why a patient needs the medications, why it's indicated, and it's always the same thing. It's that they have active, moderate to severe, steroid-resistant thyroid associated orbitopathy. No other medication has been documented in a randomized controlled trial to be effective in this population, okay? It takes about 3 to 4 weeks to get approval in Quebec. So what we do is the hospital always has tocilizumab in-house because there's tons of patients with rheumatoid arthritis and GCA and all these other illnesses. And the internist will just already administer tocilizumab while awaiting the approval, okay? And then once it's approved, if subcutaneous is desired, Roche, which is the company that has the patent on tocilizumab, has something called a joint effort program, where they just ensure that the local pharmacy gets the vials delivered. So even if they're 10 hours away in rural nowhere, their local pharmacy across the street gets the vials, the patient goes, picks up the vial, and just shoots himself in the leg at home. So it has many reasons why I was very interested in it, okay? And we were very interested in it. So our service, basically since 2022. Again, the management is not 100% uniform. There is a lot of sort of bespoke case-by-case stuff. Some internists have preferences, some oculoplastic surgeons have preferences, but this is the general management of at least my patients. That if they have active and moderate to severe or sight-threatening TAO, they usually get IV methylprednisone, and it's usually for 12 weeks. And if they're responding to IV methylprednisone, they are often getting radiation as well, okay? If that treatment is ineffective or intolerable, and if they have moderate to severe disease, they're getting tocilizumab, either IV or they're getting it subcutaneously once a week. And I'll explain how that works. If the treatment is ineffective and they have dysthyroid optic neuropathy, and either I have already done a decompression and it hasn't worked, or they cannot have a decompression, they have too many comorbidities or they refuse surgery, they're getting tocilizumab. So these are the patients that get the medication. There's some important comments before we actually get into our results. So again, there's personal preferences. Like I said, it's not rigid. Some internists and oculoplastic surgeons like one dose IV once a month for 4 months, then just stop, and we'll see what happens per the randomized control trial. Some like IV 4 doses, and then we transition them to subcutaneous tocilizumab for a week, for a few months, and then we space it out to every 2 weeks, and every 3 weeks, and every 4 weeks, and then stop, usually. Some will say from day one, we just start subcutaneously. Forget about the IV dosing, even if they have DON, we're gonna give them subcutaneous once a week, we'll see how they respond, and we go from there. Those who receive tocilizumab, remember when you're looking at the results, are the most severe and complicated patients, right? They've had multiple surgeries usually, failed treatments prior to tocilizumab. There's also heterogeneous charting with inherent limitations of a chart review. And I'm only gonna show you guys the most important results that were adequately charted. So here's our data so far. Water. You guys have questions so far? Do I take them at the end? Is that usually how it works? Yeah, okay, I was given nods for take them at the end. Okay, so here's the baseline data. So far, 19 patients who received tocilizumab, about 50% male, 50% female, average age 58, vast majority Caucasian. About 25% have significant comorbidities that made us modify treatments or decide not to decompress, for example. About 30% are active smokers. The duration of the disease before tocilizumab was started was about 1 year. The TSI antibody was quite high, almost 50. Normal is less than 1.75 international units per liter. There was a wide range, but the point is that these patients had very severe, very aggressive disease. About 5 patients of the 19 were euthyroid. The rest were either hyper, hypo, or I couldn't really tell when looking at the chart. And a very important point is that almost 50% of patients had refractory dysthyroid optic neuropathy at the time that tocilizumab was started. And if we look at the patients that failed before tocilizumab was started in all of these 19 patients, 100% had steroids. So they all had steroids, steroids didn't work. 4 of them, so 21% had radiation, 1 had rituximab, and 40% had decompression. So they had a whole stew of these therapies that did not work. And if we look at this whole group of 19 patients, the mean duration of therapy was 8 months. So on average, they got the medication for 8 months. The mean follow-up after the last dose was just under 3 years, which is very good and much better than anything else that's been published to date. The mean CAS at the start of tocilizumab was just under 4. The CAS at 4 months was 0.44, and the mean CAS at last follow-up, so 3 years out, just under 3 years, was 0.31. The mean change of proptosis was 0. If anything, the worst eye got worse by about 0.6 millimeters, so it doesn't do very much for proptosis. The amount of patients that had their diplopia improve was 21%, and the remainder were just stable. Nobody had diplopia that got worse on the medication. And success, which is kind of the most important thing, and success means that the patient is both inactive at their last follow-up and did not require any further treatment other than their tocilizumab. Okay, that's success. So we give them the medication and we say things are going so well that you don't need either more tocilizumab in the future or some other therapy, rituximab, you name it. This was 68%. So of these most difficult complex patients, almost 70% had a successful treatment. Those who failed, there were 2 patients, so 11% who were completely resistant. So I gave them tocilizumab, both were mine actually, and it did nothing. It did not improve their disease at all. There were 4 patients, so 21% that reactivated. So we give them tocilizumab, they were successful, things were going great, and then sometime in the future, they reactivated, disease got worse, and we have to treat them again with either tocilizumab or something different. The mean time to reactivation, so how often did patients reactivate, at what time, excuse me, did they reactivate once tocilizumab was stopped? It was about 5 months. Adverse events, there was one patient that had a very good response to the medication, but developed abdominal pain and fatigue. And in his case, actually, we just spaced out the subcutaneous dosing. We went from Q2 weeks to Q3 weeks, and at Q3 weeks, the abdominal pain went away. There was one patient who also had an extremely dramatic, fantastic response with the thyroid neuropathy, but she developed neutropenia, hepatitis, and hypercholesterolemia after her 17th injection. And we had to switch her to Tocilizumab, and that was her situation. So one patient that had to stop because of side effects. Sort of the most important and interesting group is the group with this thyroid neuropathies. These are the worst of the worst of the worst. And of these 9 patients, we know that 5 of them had steroids alone as an attempted treatment, and 4 of them had both steroids and a decompression, and they failed those treatments. Their follow-up after their last dose of tocilizumab was 20 months, again, much better than what's reported in the literature for almost everything else. And success in these patients, so the worst of the worst of the worst of the worst, was 55%. So 55%, which is actually a very respectable result. So over 50% chance that if they came in and I gave them tocilizumab with their terrible, terrible disease, that it actually did a fantastic job long-term. Failures, there was 2 patients that I gave tocilizumab to and it did absolutely nothing. And there were 2 patients that recurred. One patient recurred and we actually gave tocilizumab again. I'm going to talk about her later. And one patient recurred and I had to switch her to prednisone and Cellcept. Okay. So some specific Dawn cases, this is kind of more fun and more detailed. This is a patient of mine. This is a 33-year-old guy who was an active smoker and had Thyroid Associated Orbitopathy and uncontrolled Graves' disease. Well, unfortunately, the video is blocking it, but he looks pretty gnarly. Doesn't look good, okay? He developed severe sequential thyroid neuropathy on the right eye and then the left, and I kind of threw the kitchen sink at him back in that day. So at one point he had IV steroids for 10 weeks and a thyroidectomy because his Graves' disease was so poorly controlled, they couldn't get under control. I urgently decompressed his medial wall on the right side. He then developed Dawn on the left side. I gave him steroids. I urgently decompressed his medial wall on the left side. He has now received 12 grams of methylprednisone over 11 months. He's finally inactive and has normal vision. And he's looking great. There's my decompression. Maybe I could have gotten a little bit more on the right side at the way back. But his Dawn recurred. And this was 6 months after his decompression on the right side. His Dawn recurred on that side. His CAS increased to 2, his vision got to 20/80, his visual fields got worse, his color vision got worse, and it was immediately, okay, I'm giving you tocilizumab. So he started on subcutaneous tocilizumab, and by week 5, so 5 weeks after his 5th injection, his CAS was 0. His vision improved to 20/50, his color vision improved, his visual field improved, and he's the only patient of mine that's a chronic tocilizumab user. So he's now received 72 doses. He's now receiving 1 injection every 4 months of tocilizumab. And he's been inactive with near normal vision and no new treatment 3 years after his first dose. I've had many discussions with him and the internist saying like at some point we have to stop this medication. He's actually very resistant because he's so terrified of what happened in the past that he's kind of like, I'm doing well, just keep me on this. We have a little bit of a frame of mind that, you know, somehow TAO is a medication that gets immunosuppressed and then for a transient period of time and then we're done. That's actually not usually how almost every other autoimmune disease works. It's like not super common for patients with lupus and arthritis and all these other diseases to like get one dose of medication and then they're good to go. Sometimes patients do receive chronic treatment, and he might be one of them. I'm probably in the future going to stop his medication and see what happens, but right now he doesn't want that. And it's been 3 years and he's doing great. Just like I said, I'm eventually probably going to stop, but he doesn't want to right now because he's just terrified of, his previous years of sort of trauma. And this is how he looks at last follow-up. So this is a patient who's different, and I would say an ideal outcome. This is a 47-year-old female who had worsening CAS and dysthyroid optic neuropathy on the right side despite steroids. Before tocilizumab, CAS of 4, her TEL's 20/20, so not very proptotic, which is consistent because she has dysthyroid optic neuropathy. These patients tend to not have terrible proptosis, but has severely limited extraocular movements. And here's her imaging before tocilizumab. You can see on the more posterior coronal cut that the muscles are very large and that the optic nerve is getting squeezed and that there's no space for it to breathe. And that's just like the grayscale visual field that shows that she definitely has dysthyroid optic neuropathy. I gave her tocilizumab, and after her 5th subcutaneous dose, her CAS has gone down to 1. Her Hertel hasn't really improved that much, right? Even though her CAS has gotten better. And interestingly, despite the Hertel not improving very much, her imaging gets much better, right? You can see that all of her extraocular muscles are smaller. You can see that the nerve at the exact same cut is way less congested at the apex. Her visual field is already getting better at 5 weeks. And she received a total of 28 doses of IV tocilizumab. And it has been 3 years since her last dose. So she has not received the medication for 3 years. And she has near normal vision, free extraocular movements now, is completely inactive. So a very, very good success case. This is a patient of mine that recurred, and I'll show you the last case that I talk about, just to show that it's not always perfect. I don't want to give you like a rose-colored glasses, point of view. 77-year-old with Dawn on both sides, a CAS of 4. While she was on Solu-Medrol, her CAS improved. It got to 2 on 10, but her vision got worse on both sides. Her color vision got worse, visual fields got worse, and she had profound extraocular muscle limitations. So she almost had frozen globes on both sides. She refused decompression, so I started her on tocilizumab intravenously because that's what the internist actually wanted to do. And 1 week, so 7 days after her first infusion, her CAS went to 0. Her color vision and her visual acuity dramatically improved on both sides. And you can already see that this is in French, but she has a mild left hypotropia. That's all she has. There's a mild left hypo 1 week after the first injection, and she had almost frozen globes before that. So a very dramatic response. 4 months after her last infusion, her normalization, her EOMs were completely normalized. Here's her orthoptic exam. She's completely ortho in all gazes. This is 4 months after the last infusion. But 5 months after tocilizumab, she had worsening diplopia. I brought her in, the orthoptist looked at her. She now has a 10 diopter left hypo. And we had a long discussion. There isn't a clear answer on what to do in these patients. And I decided to give her tocilizumab again. This time, 2 weeks after her first infusion, again, her strabismus much improved. She now has a 2 diopter left hypo in primary. 7 months after her last dose, she has normal vision and free extraocular movements. If she recurs again, the question is like, what do you do in these patients? She might recur again, I don't know. And the answer is maybe we're gonna treat her like the first guy and give her tocilizumab chronically. Maybe one thing that I haven't done yet, but that I might, is that I might give her tocilizumab, which we know in her case is working very potently short-term, and combine it with radiation that has a much more long-term protective effect. Maybe it's a different medication. Maybe by then it'll be Tepro, I don't know. What are the take-home points? The first is that TAO is a common but complex inflammatory disease of the orbit. You really have to have an up-to-date and structured approach when dealing with these patients. When the disease is active and the patient is sufficiently symptomatic, outside of the US, standard first-line treatment is steroids plus or minus radiation, and that is more than justifiable. Glucocorticoids are inexpensive and effective in anywhere from 40 to 80% of patients, but that means that 20 to 60% will fail, and this is a very challenging scenario with not a ton of data. Tocilizumab is the most studied immunomodulator in patients that have failed steroids. It is inexpensive, at least in Quebec, and has an acceptable safety profile in rheumatoid arthritis patients. The best publications on steroid-resistant patients reveal IV tocilizumab to be very effective at inactivating disease, Roughly 90% of patients are inactive at 10 to 24 months. But usually it has a minimal effect on proptosis and diplopia. There's some exceptions, like my patient and other patients, but on average, it usually doesn't do a great job with those outcomes. Our experience at the University of Montreal has been unique in the sense that they're all glucocorticoid resistant, 32% are smokers, but 50% have dysthyroid optic neuropathy and very long follow-up. And despite this very major negative selection bias, our results have so far been very encouraging. 68% are inactive at a mean of 3 years follow-up with no further treatment. Of those with DON, so the worst of the worst, 55% improved or resolved at a mean of 2 years with no further treatment. The medication is flexible, it can be easily spaced out, it can be continued for months or even chronically, and it is inexpensive and can be administered subcutaneously at home, which is very important for a lot of my patients, the medical team, and sort of the burdened Canadian healthcare system. That's it. Thank you.
Well, thank you, Evan. That was fantastic. I don't know if there's questions in the room, but I do have one for you. I appreciate that you gave a Canadian perspective because I think that's always valuable and practical for us. Just out of curiosity, how does that contrast with the American approach?
The American approach, I mean, my comment is that it's a little bit, I don't want to use the word influenced. It's influenced by, one, the fact that the drug that is teprotumumab has completely overtaken the market, and it's overtaken the market because of multiple factors. It got FDA approval for any patient. Is this your question, Amandeep? Like, what do Americans do with these patients? Okay, so my answer is that pretty much everybody gets teprotumumab. And the reason why they get teprotumumab is that the initial trials and the initial experience with the medication was dramatically fantastic. And because it was dramatically fantastic, it became very quickly adopted within the US. And the problem is that when a medication does dramatically well short-term, but there's a slow burn, and over time, patients sort of start coming back a year, 2 years later, they're having to retreat, there's more issues. Sort of, I think human consciousness is one where we're quick to remember the dramatic short-term result, and it's easier to sort of forget the slow burn of patients that are coming back and that are not doing well. And there are more and more studies that are kind of pushing this point home. But teprotumumab has penetrated the market aggressively. They are very, it's a very influential medication and a lot of interaction between the pharmaceutical company and between oculofacial plastic surgeons. It's a very lucrative medication as well. And for all of these reasons, it's kind of a scenario where for the last 4 years, it's all teprotumumab. However, I have had meetings recently with colleagues from Columbia and New York and Cleveland Clinic and other places. And there's definitely a shift in the mentality where some of the larger centers are starting to say, like, we have to start doing something different here because we're realizing that a lot of patients are not having long-term success with this medication.
Evan, yeah, I can actually attest to that. At the last ASOP for spring meeting, there was definitely a sense that a lot of people who were prescribing teprotumumab a lot have really reduced their prescription of it. And actually, one of the topics that was very popular at the meeting was surprisingly radiotherapy. It seems like they've discovered it. So
yeah, radiation is something that we use a lot of in Canada. And I would say, to further your question, Amandeep, radiation is not very popular in the US. It's not very popular for 2 reasons. One is that there was a trial that was very flawed, unfortunately, out of the Mayo Clinic, where they looked at patients who received radiation and radiation did nothing. But these were patients that had had disease for a very long period of time and likely were already clinically inactive. So they were not the group of patients that were suitable for the treatment. And because of that trial, there's a lot of difficulty getting authorization from insurance companies in the US for radiation. So it's viewed as like an off label. There's a lot of resistance. There's also a stigma towards radiation as just a general term. So I know when I was in the US training and when I speak with a lot of my colleagues who know that it's something that can be quite useful in some patients, there's issues with insurance companies in terms of getting it done. So there's not as much radiation in the US. There's a large amount of teprotumumab being given, very little tocilizumab with the exception of some pockets in some states.
Great, thank you. There is a question from Dr. Ostreicher here. asking if the two medications have been compared.
No, thank you for the question. Do you mean tocilizumab and teprotumumab?
Right.
So no, there's never been a trial or any type of study that has compared directly tocilizumab with teprotumumab. None. Another thing that I think sort of hurts tocilizumab a little bit is that the main outcome measure for the teprotumumab trials is proptosis reduction, which on its own, in my opinion, is flawed. I think proptosis reduction isn't the most important thing, but that's sort of the main outcome measure. And the issue is that teprotumumab does an incredible job short term with proptosis reduction. You get these incredible dramatic improvements, and then they often will get worse and regress over time. Tocilizumab, unfortunately, doesn't have that effect. Tocilizumab is very good for clinical activity and is okay for proptosis at best long term. So it's not a medication that you give and you see patients within 1 week or 2 weeks suddenly regress and their eyes that are bulging out of their head are now back in place. So because of that, that's another reason why tocilizumab, I think, isn't as picked up by a lot of people, because the early effects don't smack you in the face like teprotumumab. And no, it's never been compared face to face.
There's a question from Alan as well. He's got his hand up.
Yeah, is there ever a situation where, the patient's sight is at risk and things are just going bad quickly that you might want to use a steroid, like both agents? And another question is, if in patients who are having side effects of the medication, would you ever consider like a subtenons injection? Would that work, do you think?
So the answer to your first question is yes, definitely. When things are going bad, I didn't get into this because I didn't want to keep you guys here for like 3 hours. But when somebody gets tocilizumab, on average, it takes, in our experience, anywhere from 1 to 5 weeks before it kicks in. Solumedrol kicks in instantaneously. So every single patient that comes in, especially those that are in dire straits, will get immediately with me intravenous solumedrol and tocilizumab. They get both. So you're getting the solumedrol short-term effect is what we're hoping for, awaiting the longer-term kick-in of tocilizumab. So that's the first question. The second one is, I have no idea for subtenons tocilizumab. I don't know. I have no experience with it. It's an interesting idea. There have been studies where people have injected retrobulbar rituximab or steroids in patients with thyroid associated orbitopathy, but nobody has ever injected and published retrobulbar tocilizumab or subtenons tocilizumab. It's actually kind of an interesting idea. So no, I don't know. Interesting question. Yeah.
Just if they're getting toxic on the medication, this may be, and it's working, this may be another route to decrease systemic absorption.
Exactly, and that's exactly what we do in some patients in select cases for retrobulbar steroids. Patients that are too contraindicated for systemic steroids and that are really in a tough spot, there are some people who will inject retrobulbar steroids. So yeah, very good point. Yeah.
Good question.
Yes.
Thank you so much for the great talk. I was wondering, with the tocilizumab, once you administer it and you're looking for a response, let's say they have a partial response or a reduction in their CAS score, how do you know after 4 to 5 weeks whether or not you want to continue the therapy? Let's say they go from CAS score 6 down to 4 or 5 down to 2. Do you continue until the CAS score is 0 or 1, or do you kind of stop and see how they do?
So thank you for the question. It isn't cut and dry. What I would say is that everybody gets therapy in general for at least 4 months. That's like the basic. Either you're getting 1 IV infusion once a month for 4 months, or you're getting subcutaneous once a week for at least 3 to 4 months. And then after that, it's I sit down and I look at them. There's a little bit of like gestalt, how is this patient doing? Are they tolerating it well? Do they look so great that I'm going to say, let's just stop it? Or were they so terrible initially that I'm scared to stop them, so I'm going to give them a longer duration of treatment? So there isn't a binary response to this. It kind of depends on how I think they look. It's not purely the clinical activity score either. Sometimes their CAS is 2, but it was like 7 to start off and they're looking great and I'll stop them. Sometimes I'll say, no, I want their CAS to go to 0. So it's a little bit of kind of the art to it and your own experience. And also I did, again, not to go into too much detail, I explained that these are patients that have to be clinically active, but it's also true that they don't have to technically be clinically active, right? They don't have to have 4 or more on 10. If somebody has 2 on 10, but it's rapidly worsening strabismus and massive edema of their eyelids, well then I'm gonna almost surely immune suppress them, even though they're technically not active for the clinical activity score. There's always like a little bit of, how much salt do you put in the soup? It's more subjective. Yeah.
A multi-type version of the CA score with like different weights, because it seems like
There's one other large scoring system called the VISA classification, which actually originated out of UBC, that a lot of people use. But the truth is that I think the VISA system is great because it forces, especially people who have less experience, to look at every single aspect of the disease. Like there's classic mistakes people make where somebody comes in, they have a CAS of 0. And they think, oh, they have a CAS of 0. This patient can't have this thyroid optic neuropathy, but they have terrible thyroid optic neuropathy. You can definitely have it with a CAS of 0. And the VISA scoring system forces you to look at every single thing on every single patient, and it forces you to remember to look at everything. My personal opinion is that the issue with the VISA is that it's harder to study. It's like harder to get like results in terms of like publications. By the way, we're publishing all of this. Like the manuscript is finished and it's already been sent out. The publication that's going to be coming out soon is not as up to date as what I just showed you. The publication was from when we had shorter follow-up. This is from much more recent follow-up. So my comment is, yes, there's a better system, which is called the VISA system. But my opinion is that if you follow the CAS and you don't forget and you always write down if there's cornea breakdown, if there's a thyroid optic neuropathy, you're largely doing the same thing. And I still stick with the CAS purely from a research standpoint. So, but yes, the VISA system is probably better, especially if you're less experienced treating these patients. Yes?
Is there anyone that's used Toci and Tepro together?
So the question is, can you guys hear virtually the questions?
Yes.
Okay, so has anybody used Toci and Tepro? And the answer is no. Nobody has done that, but my strong opinion is that when it becomes approved in Canada and the price goes down, like we can't, it's kind of crazy. Like, I have a colleague at, Mass Eye who's given Tepro to like almost 200 patients over 2 years. So when you think about the cost, it's like 500,000 US a pop times 200 patients. So it's very, very expensive. So my comment is that if it gets approved, once it is approved and the cost goes down, I view teprotumumab as a much better version of steroids. It's something that short-term does a very, very good job. And I view tocilizumab as something that long-term does an excellent job. So I think that your question is a good one, and that I think that in the future, once available, for a lot of patients, I'll probably be giving teprotumumab for its short-term effect at the same time as tocilizumab for its long-term effect. So teprotumumab for a brief duration, tocilizumab for a longer duration, and maybe this will help these patients the best. Another thought is teprotumumab short-term plus radiation. Teprotumumab will reduce the proptosis, reduce the clinical activity, and radiation will sort of lock them in place. So these are other ideas also, but we can't yet play with that in Canada, and nobody has done that in the US.
One quick question. If you had to envision what you would do, would you potentially do steroids, Tepro, radiation altogether? You have the known benefit of steroids, which all work in many, many diseases.
So my answer is I don't know. I'd also have to know from a systemic standpoint, the mix of these medications and the age of the patient. Radiation is something that is very beneficial in a lot of these patients when chosen properly. There's also contraindications for it. Like if it were me, for example, okay, and I had terrible thyroid associated orbitopathy and I could do anything I wanted, I would give myself probably teprotumumab to start and tocilizumab. I probably wouldn't radiate myself because I'm 40. And radiation does have a risk of developing malignancy, especially if you're younger in life. So in my case, I probably wouldn't radiate. But if somebody were older, I probably would do, right now what I would do is potentially tocilizumab plus radiation if they respond well to it, or when teprotumumab becomes available, teprotumumab plus radiation. So it's kind of, that's my best answer. Yeah.
One comment I just wanted to make is one of the nice things about tocilizumab is of all the big treatments for thyroid eye disease, it's the only one that doesn't really affect glycemic control,
That's right.
right? With the corticosteroids, you'll often make diabetics worse, and also with teprotumumab. Has that kind of ever played a role in your decision making?
I mean, it's just really nice because a lot of these patients are sick. A lot of them are obese, have diabetes, are smokers, have other comorbidities, and it is very helpful that I don't have to worry about hyperglycemia. And to be perfectly frank, it is, you know, it's what I always tell the residents. In some ways, it's a perverse system where the easiest thing to suggest is the thing you don't have to do yourself. It's kind of like temporal artery biopsies, right? I mean, if you're an internist and you have like a 1% thought of maybe it's GCA, temporal artery biopsy, because they don't have to do it, right? But then somebody else has to do it. And I guarantee you that if they had to actually do that surgery themselves, the request rate for TAVs would be down to zero. Well, not zero, but significantly decreased, okay? There is a luxury to having a team in place where we had a meeting with the internists and we said, like, listen, we're the masters of this disease, but I am not at all a master of these systemic side effects. Will you help us? And because we met face to face, we took the effort to do it. They said yes. And it makes it obviously, it incentivizes us even more to give the medication because we know it's generally well treated. We have a team that's set up. I see a patient in clinic. I can easily I usually call or text my buddy and say, like, this is a tocilizumab patient, and he's like already on it. So it's a lot easier. The truth is that even steroids are something that I don't refer to internists. I take care of myself. And there's always a part of me deep down in truth that's kind of like the side effects of steroids. Like, what if this happens? Like, I'm gonna have to deal with the hepatitis and like then refer them urgently and deal with the hyperglycemia, and I'm not an internist. So yes, it's nice that it has no effect on diabetes, which almost all these patients have.
In terms
Okay,
of,
well, we will wrap it up here. Evan, I want to thank you for the wonderful rounds this morning. And I have to admit, George was absolutely correct. You have a wonderful teaching style. I think that came across very clearly this morning. The way you break down complex topics into such simple and relatable concept is really remarkable. So congratulations to you. And thank you for taking the time to teach our residents this morning. For our audience, we do have grand rounds with Dr. Larissa Dershko next week. So we will resume grand rounds next Friday morning. Thank you, everyone. Have a great day.
You guys have more questions about this?